Hi, my name's Abigail Roelke. I'm a pre-pharmacy student at the University of Arizona, and my presentation's on disulfiram in the management of alcohol use disorder. So my question is, how does disulfiram work in the management of alcohol use disorder, and what are the potential risks and benefits associated with its use in combination with other pharmacological treatments? The learning objectives are explain the role of disulfiram in the management of alcohol use disorder, its mechanism of action in the disulfiram alcohol reaction, identifying FDA approved indications, pharmacokinetics, dosing and administration points, recognizing common and severe adverse reactions, contraindications, and precautions, reviewing the potential risks and benefits of using disulfiram and the disulfiram in combination with other pharmacological treatments for alcohol use disorder. So, alcohol use disorder is a chronic condition that involves the inability to control the amount of alcohol consumed, regardless of health and social repercussions, and it can range from mild to severe cases. It is caused by multiple factors, including psychological, social, biological, or environmental, and multiple neurotransmitter systems are involved, including GABA, glutamate, and dopamine. There are 3 different pharmacological treatments available: disulfiram, which is an alcohol deterrent therapy, acompressate, which helps reduce alcohol withdrawal symptoms, and naltrexone, which reduces alcohol cravings. So, alcohol withdrawal occurs due to an imbalance between our GABA and glutamate neurotransmitters, and as seen in the picture, and can cause a variety of symptoms between minor and major. Some minor symptoms would be anxiety, headache, tremors, and GI upset, while major can be delirium, hallucinations, seizures, and even death. So some brief history on disulfiram. It is an aldehyde dehydrogenase inhibitor. It was FDA approved in 1949, making it the first drug approved to treat alcoholism. It deters drinking by causing severe reactions to alcohol. It was used in aversive therapy that required supervision and monitoring by healthcare professionals. And it was discovered by workers in a rubber factory who were exposed to disulfiram and then later became ill after drinking alcohol. Some FDA-approved indications include alcoholism and alcohol dependence in adults, while we have 2 off-label uses: cocaine use disorder and contact dermatitis caused by nickel. The evidence supporting these 2 uses is very inconclusive, so we are unsure of the efficacy of disulfiram with them. So the mechanism of action of disulfiram, it is an irreversible inhibitor of aldehyde dehydrogenase, and it stops the breakdown and leads to an increased amount of acetaldehyde. So in the alcohol metabolism pathway, we go from ethanol, we use alcohol dehydrogenase to turn it into acetaldehyde, and then we use aldehyde dehydrogenase to turn it into acetate, which is more decomposable in our body. But disulfiram inhibits our aldehyde dehydrogenase, and so it keeps that acetaldehyde in our body, which causes such a reaction between alcohol. So for our doses and administrations, the only administration that we have known is our oral tablets, and the initial dosage can go from 250 milligrams to 500 for the first 1 to 2 weeks, but it may be adjusted based on our response to a range of 125 to 500 milligrams once daily, but the max will always be 500 and we won't go above that. You do not want to give this medication until the patient has been away from alcohol for over 12 hours, just in case there is some alcohol left in the blood. It can cause that reaction and cause some unpleasant side effects. And then in combination with other therapies, the dose is adjusted depending on the medications and those side effects. So naltrexone and disulfiram, they both can cause hepatotoxicity, so we want to make sure that both of those doses are lowered and don't increase the risk of that happening. So for our relevant pharmacokinetics, the onset of action is 12 hours, duration is up to 14 days, and the half-life is 12 hours. So alcohol should not be ingested for at least 12 hours before taking disulfiram and avoided for the next 14 days after that last dose. So for our benefits and important information, it helps people with alcohol use disorder avoid drinking, and this is because it is such a strong deterrent and causes such an unpleasant reaction that people want to stay away from alcohol when they're on this medication. And it is very effective in motivated patients, specifically ones that are doing supervised dosing and therapies along with that medication. And then we want to make sure that we're telling patients to be warned of alcohol in disguised forms like vinegars, cough mixtures, sauces, because regardless if it's not alcohol, that ethanol will cause a reaction and won't be able to be broken down properly. So disulfiram does not remove cravings or help withdrawal symptoms. So this is more of a medication that if you take when you want to be sober and not reduce just the amount of alcohol you're ingesting. So for our risks and adverse effects, some common adverse effects include fatigue, mild drowsiness, headache, and dermatitis, and some more serious adverse reactions include hepatitis, liver failure, optic neuritis, and psychosis. Most of these effects will resolve within those 2 weeks after the first 1 to 2 weeks, but they are known to stick around sometimes. So for the contraindications, if you have a known hypersensitivity to disulfiram or other thiourea derivatives, you want to keep away. Recently taken metronidazole or paraldehyde or alcohol. And if you're diagnosed with severe myocardial disease, coronary occlusions, or any sort of seizure disorder, you want to stay away from disulfiram. And our black box warning is disulfiram should never be used in patients that are intoxicated by alcohol, or if they're not informed that they're going to be taking this. If they're in and out of consciousness, you do not want to put them on disulfiram at the risk of them not fully understanding what it could cause. And then our reaction between disulfiram and alcohol are dependent on the doses, but in small amounts, it can induce flushing, throbbing, headaches, respiratory issues, hypotension, tachycardia, and a lot of other things. But then in large amounts, it can lead to heart failure, unconsciousness, convulsions, and death. So with our combination therapy, the risks and benefits. So with disulfiram and naltrexone, there are no known advantages to combining these medications. They do both target both our reward and aversion pathways, but they will increase your liver enzymes that leads you to that hepatotoxicity risk. But with disulfiram and acamprosate, it improves the effectiveness of acamprosate and is very able to reduce those alcohol withdrawal symptoms by balancing our glutamate and GABA, and that helps maintain our sobriety as well. But the risks are diarrhea. And then with our disulfiram and benzodiazepines, it is more of an acute treatment, not long-term, but it is very effective to maintain that sobriety because it does balance that glutamate and GABA. But there is a dependency risk if you do use benzodiazepines for a long term. And then for our summary, disulfiram manages alcohol use disorder by inhibiting that aldehyde dehydrogenase that causes that increase in acetaldehyde and causing that unpleasant reaction from drinking alcohol. It is a powerful deterrent, and it is an effective option when the goal is complete sobriety and not reducing the amount of drinking. It has serious reactions with anything containing alcohol, even in small amounts, so it requires close monitoring to ensure that patients are being safe and aware of those hidden alcohol sources. And it may improve abstinence when it's paired with other medications that reduce cravings, withdrawal symptoms, and help with acute alcohol use disorder. And here are my references.